Okay, now let's discuss capnography. Is excuse me, exhaled carbon dioxide (CO2) monitoring, also called end-tidal CO2 or end-tidal carbon dioxide monitoring, or capnometry with multiple names, is a non-invasive method of measuring levels of carbon dioxide in exhaled breath. Capnography is a recording or display of the exhaled carbon dioxide levels measured by the capnometry. When first introduced in the pre-hospital care, capnometry was used exclusively to verify proper endotracheal tube placement, as it is an excellent indicator of that. In the trachea, the detection of adequate levels of exhaled CO2 following intubation confirms the tube is in the trachea or above and not in the esophagus. More robust technology provides accurate, non-invasive measurement of exhaled CO2 levels, thus providing medical personnel with information about the status of systemic metabolism, circulation, and ventilation. The use of capnography and capnometry has become commonplace in the operating room, in the emergency department, and now pushing further into the pre-hospital setting. Various terms have been used, have been applied to capnography, and a recent review of them may help understand the material in this that we're going to cover. So capnometry is the measurement of expired CO2. It typically provides a numeric display of the partial pressure of CO2 in either torr or millimeters mercury. Remember, they're the same measurement, or the percentage of CO2 present. Capnography is the graphic recording or display of the capnometry reading over time. A capnograph is a device that measures expired CO2 levels. A capnogram is the visual representation of the expired CO2 waveform. End-tidal CO2 or ETCO2 is the measurement of the CO concentration at the end of expiration, or the maximum CO2 level. PET CO2 or PET CO2 is the partial pressure of end-tidal CO2 in a mixed gas solution. And PA CO2 represents the partial pressure of CO2 in arterial blood. The end-tidal gradient is the difference between partial pressure of arterial CO2 and the end-tidal CO2, and is calculated as PaCO2 minus EtCO2 equals end-tidal gradient. So the difference between those two numbers, or those two measurements, will be your end-tidal gradient. The value is normally less than 5 millimeters mercury. However, increase in dead space ventilation, the ventilation of non-perfusing lung tissue, reflects the ventilation perfusion mismatch, or the VQ mismatch. This occurs in pulmonary embolism and similar processes. As dead space ventilation increases, the EtCO2 falls, thus widening that end-tidal gradient. CO2 as a normal end product of metabolism is transported by the venous system to the right side of the heart and then onto the lungs, where it diffuses in the alveoli as the gas exchange takes place, is removed through the body through exhalation. When circulation is normal, exhaled CO2 levels change proportionately with ventilations and are a very reliable estimate of the partial pressure of carbon dioxide in the arterial system. The PaCO2. Normal PaCO2 is approximately 40, and a normal exhaled CO2 is just 1 to 2 millimeters less, or 38 millimeters mercury. So that's where we see here the arterial blood gas will show a PaCO2 of 35 to 45, and end-tidal CO2 may show 30 to 43, because there's just that little bit of difference, couple millimeters mercury difference, that you're going to see in your percentages. When perfusion decreases, as occurs in shock or cardiac arrest, exhaled CO2 levels reflect the pulmonary blood flow and cardiac output, not the ventilation. Decreased levels of exhaled CO2 can be found in shock, cardiac arrest, pulmonary embolism, bronchospasm, and with incomplete airway obstruction such as mucus plugging. Increased levels of exhaled CO2 are found in hypoventilation, respiratory depression, and hyperthermia. CO2 is detected by using either a colorimetric or an infrared device. It can be reported as a percentage, the amount of CO2 in a given volume of gas, or as a partial pressure in millimeters of mercury. Our colorimetric devices is a device that is disposable end-tidal CO2 detector that contains a pH-sensitive, chemically impregnated paper, or pH paper, encased with a plastic chamber. These are usually kept sealed in a vacuum sealed package to limit contamination. It's placed in the airway circuit between the patient and the ventilatory device, so either the bag mask or potentially a ventilator, whatever you happen to be using. This is put in that circuit. And when the paper is exposed to CO2, the hydrogen ions are generated and cause a change in pH. Causing a color change on the paper, the color change is reversible and changes breath to breath. A color scale on the device estimates the end-tidal CO2 level. This will give you a good basic idea. These are great for checking for proper placement of an ET tube. You're looking for that color change, and you want to make sure that color change, there's a little scale around the outside that you would match that color to. You got to look fairly quickly because the paper changes back pretty fast. So they cannot detect hyper or hypocarbia. The change is not fast enough to give a breath by breath. This will give you an initial pretty decent indicator. If gastric contents or acidic drugs, so if you give like endotracheal for example, or endotracheal, they're the same thing. Epinephrine down the ET tube, and they contact the paper in the device, like it's exhaled back up. If droplets hit the paper, that is acidic and it's going to show different. And it's not going to be accurate. That's part of the problem. Is these are good right up until the paper gets damp, and as we know, we exhale humid air, and we lose fluid. That way, we can through respiration or ventilation, we do lose a certain amount of moisture from the body, and that will eventually soak that paper, and then the paper is unreliable because it's wet. So that is one of the downfalls to the paper ones. Or the color metrics. So here we look at some basic rules of the capnography. So a sudden drop of end-tidal CO2 to 0, that's a big problem, obviously. So we either intubate it into the esophagus, and we're no longer getting a true measure of the gas exchange because we're not getting gas exchange from the stomach. The ventilator disconnected, or your bag mask became disconnected, or there's a defect somewhere in there, or a defect in the CO2 analyzer, or maybe your little capillary tube that runs from the circuit to the monitoring device has come loose. A sudden decrease of end-tidal CO2, but not to 0, you may have a leak or an obstruction. There may be a partial disconnect in the ventilator circuit, and there may be a partial airway obstruction, secretions or otherwise. These are things that give you a clue that something has changed with your patient. Exponential decrease of end-tidal CO2, we've got either a pulmonary embolism that has progressed or declared itself. Cardiac arrest would cause a huge decrease. Hypotension, a sudden drop in blood pressure, which would definitely influence gas exchange, and at the cellular level and at the alveolar level. And severe hyperventilation. I've demonstrated this before in class. I don't know if I'm going to do it anymore because it does cause a headache. But I can get my your end tidal CO2 measurements. You want to maintain between 35 and 45, and I've gotten mine down to 22 before through hyperventilation, and it does not feel good. 1 star, do not recommend. Or you get a change in your CO baseline. You either got a calibration error, there's a water droplet in the analyzer, or there's a mechanical failure somewhere. So these are things to look for, and these are things that are just tips to help troubleshoot what's going on the flip side, we have sudden increase is assessing an area of lung previously obstructed. So a mucus plug may have broken loose, or atelectic tissue has now, or atelectic alveoli have now opened with positive pressure ventilation, and now that area of lung is now reusable and working. You have the tourniquet has been released, now releasing those the lactic acids and the CO2 that is built up behind that tourniquet is now released and flooded into the blood, or you've got a sudden increase in blood pressure. You get a gradual lowering, hypovolemia. As you're bleeding out, you're losing that oxygen carrying capability. If you're losing oxygen carrying capability, you're also losing CO2 carrying capability. Your cardiac output may be decreasing. Your body temperature, they may be becoming hypothermic, and metabolism is slowing. And you get a gradual increase. You may be developing fever. They may be hypoventilating. And CO2 absorption, partial airway obstruction from a foreign body, or a reactive airway disease such as asthma. You may be worsening those conditions. Infrared devices or electronic exhaled CO2 detectors can be qualitative or quantitative.